Hi, today we will talk about the esophagus. This is another lecture in the series of thoracic surgery for undergraduate students. So let's start with some terminology. What do we mean by dysphagia and odynophagia? So dysphagia is a difficulty in swallowing, and odynophagia is painful dysphagia. And these are important. One of the main symptoms the patients with esophageal problems might present with could be presenting with either difficulty in swallowing or it is painful swallowing. So let's think about what might be the causative factor. So if we start anatomically with the upper part, which is the oropharynx, let's think about what might be the causes. So one of the causes could be loss of the tongue function, so patients with muscular disorders like myasthenia gravis. It could be also problems with the pharynx. It could be also like a pulmonary symptoms, patients with brainstem strokes or cerebrovascular accidents, or hyperthyroidism might have a pharyngeal problems, or also myasthenia gravis. Or it could be mechanical obstructions in the form of Zinker diverticulums or tumors or inflammatory strictures. In the body of the esophagus itself, it's useful to categorize the causes in order to facilitate their memorization. So if we think about things that will cause obstruction in the lumen, or things causing obstruction from outside, or things like motility disorders impacting the motility of the esophagus itself without the presence of organic lesions, or other causes. So let's think about interluminal obstruction. If we think about it, we might think about things causing a stricture, masses or tumors. There could be hypertensive sphincter, could be foreign bodies or impacted foreign bodies, and there's rings and whips, which also might cause the obstruction, as well as obstructive strictures. We can also think about the extraluminal obstruction. So this means that there's something compressing the esophagus from outside. So it could be a lymph node, could be tumors, mediastinal masses, could be retrosternal goiter, also could be an aneurysms or apparent right subclavian artery causing like a ring, causing compression on the esophagus. And this is an apparent right subclavian artery. It could be right-sided aortic arch. So all these structures are compressing in the lumen of the esophagus from outside. It could be also motility disorders, and this is an important entity. So the motility disorders are problems with on the wall of the lumen of the esophagus itself without the presence of an organic lesion like masses. So they are achalasia, which is the commonest type. There's a rare thing, Chagas disease, which is more present in the Latin America, and amyloidosis, scleroderma, which is an autoimmune disorder, and neuropathy in advanced stage, and diffuse esophageal spasm. The most common entities is the achalasia and diffuse esophageal spasm. There are other miscellaneous causes like Crohn's disease, and also some infections might cause problems in the causing dysphagia. Like for example, Candida might cause also odynophagia. How can we assess the esophageal function and motility? So let's start with esophageal manometry. With esophageal manometry, we assess the motility of the esophageal body. So we assess the propulsive motion and also the function of the upper and lower esophageal sphincters, and this will help to detect the achalasia and diffuse esophageal spasm and nutcracker spasm. So with achalasia, there is a failure of lower esophageal sphincter to relax, and the loss of the peristalsis within the body of the esophagus. So this will lead to progressive dilatation of the esophagus due to inability to propel the food in the lower esophageal sphincter to the stomach, and the food will accumulate in the esophagus. The other entity is the diffuse esophageal spasm, and diffuse esophageal spasm there is a high amplitude and long duration of repetitive contractions of the body of the esophagus, which do not result in propulsion of the food from the esophagus to the stomach, and usually patients will have chest pains. So another thing is ambulatory 24-hour pH monitoring to detect the reflux diseases. And sometimes also we can do a pyreflux monitoring to assess the reflux of the bilirubin through the esophagus. We can do Bernstein test, which is a test to reproduce the patient's symptoms with acid perfusion to assess if the patient has reflux. So let's start with achalasia. Achalasia is a motility disorder, as we mentioned before, characterized by failure of relaxation of the lower esophageal sphincter. Patients usually have achalasia because of the damage of the nerves of the esophagus, either through bacterial infections or other genetic hereditary causes. The exact cause, underlying etiology, is still unknown, but the thing is, we have hypertrophy in the circular muscle layer of the esophagus that causes the failure of lower esophageal sphincter to relax with the swallowing, usually occurring in young and middle-aged women, and seen also in elderly people with recurrent respiratory infection. So patient will have the difficulty swallowing, as we mentioned, because there's failure of relaxation of the lower esophageal sphincter of swallowing, and because the esophagus will be progressively dilated with food particles, this might result in regurgitation of the food and recurrent respiratory infections. And because of the inability to swallow, the patient will have a weight loss and might have also heartburn. That is a chest X-ray showing an air fluid level, as you can see, in the posterior mediastinum, and that's because of the progressive dilatation of the esophagus with food. And that is the lateral chest X-ray also showing the same thing. The esophagus is dilated and will have an air fluid level from inability to propel the food to the stomach. So the chest X-ray, if the patient has if the patient is having early in the disease or the esophagus still not dilated, it might show a normal chest X-ray or either widened mediastinum. Sometimes there is an absence gastric air bubble because inability of the air even to enter the lower esophageal sphincter, and if the patient had recurrent might have signs of recurrent respiratory tract infections. So if we did a barium swallow, which is a useful initial diagnostic tool to assess the esophageal function and motility disorders, you will find a dilated esophagus, which we might have also in irregularity of the density of the barium because of the food particles mixed with the barium. And there will be a smooth tabbering in the distal esophagus just above the diaphragm, and there's no gastric bubble because the air is unable to enter the lower esophageal sphincter. With the endoscopy, you will find the dilated esophagus, food particles, and you will be able to pass the lower esophageal sphincter because this is not a mechanical obstruction. However, when you're trying to do a frequent insufflation to open the lower esophageal sphincter, it will not open by itself. So the treatment, we start first with oral medications like nitrates, which try to relax the lower esophageal sphincter, and also calcium channel blockers. And there's endoscopic dilatations with either balloon dilatation or forceful dilatation, try to release the lower esophageal sphincter. And this is a balloon dilatation of the lower esophageal sphincter, and sometimes they can inject botulinum toxin, try to paralyze the lower esophageal sphincter and help it to dilate. The surgery is a modified Heller cardiomyotomy. So cardiomyotomy is a surgical longitudinal sectioning or incision along the outer longitudinal muscle and the inner circular muscle without damaging the submucosa and mucosa. So it can be done with laparoscopy or could be also done from the thoracoscopy. And that is the myotomy incision. However, some patients might have an acid reflux from overcorrection or from relaxation of the esophageal sphincter with having the symptoms on the opposite side, like acid reflux. Let's get again to the corrosive esophageal injury. Corrosive esophageal injury, as you know, potass has been used for a detergent agent in our country for a long time, and because it simulates the color of the milk when it is distilled in water, children used to mistake it for milk and drink it, and then we have a population now which are elderly patients now with corrosive esophageal injuries having the complications of the chronic stricture. So people usually working also in factories or labs might have experienced the esophageal corrosive injuries. So we have different mechanism of necrosis depending on the agent swallowed. So it could be either an alkali or an acid. With acids, it's called liquefactive necrosis, which is much more severe than the coagulative necrosis caused by acids, because usually coagulation will stop the extent of injury. So what is the classification? First, it will cause a superficial burns, like similar to the skin burns. So that will be superficial injury, usually resolved with no long-term sequelae. And then they have second degree is medium or transmucosal burn. And then we have the full burn or full thickness burn, which is the most severe type, and usually it ends up with cicatrization and inflammation, causing also periesophagitis, and also might lead to perforation, which is more serious. And perforation, it will result in extent of the inflammation to the mediastinum and the pericardium, and might also cause bronchoesophageal fistula. So what the phases of the esophagus? Initially, there will be an acute necrotic phase. Patients will be sometimes acutely unwell, having edema and inflammation and swelling of the tongue and the upper oropharynx, unable to swallow, have a dropping of saliva, and then we have the ulceration, granulation tissue, and then later on will end up by stricture, fibrosis, and cicatrization. So the treatment initially will be supportive treatment, so parenteral fluids, corticosteroids try to decrease the inflammatory extent, antibiotic coverage, and then later esophagoscopy and radiography if the patient stabilized. If there is no burn or a first degree burn, well, we can continue the oral feeding. We can start the oral feeding, but from clear fluids, and then gradually into full diet to make sure there's no perforation, under cover of antibiotics, of course. And then for the second and third degree, we'll need an esophageal splint, we'll need an additional, we might think about jejunostomy or gastrostomy for alternative feeding, or siliconized catheter to allow for feeding without injury. For the chronic stages, if it is a short segment, we can dilate it antegradally. For long segments, we can do the Tucker dilator or dilated retrogradely. In patients with frequent dilatation or severe symptoms, then they will require a colon interposition. That's the picture for Savary and Tucker retrograde dilators and the retrosternal colon interposition. The reflux is one of the commonest symptoms in patients presented with usually heartburn. Another complication, important complication, is paroesophagitis. So reflux is very common, and it is presented with frequent attacks or bouts of feeling of reflux of heartburns due to the stomach, due to the reflux of HCl into the lower part of the esophagus. And usually patients will have the common symptom of heartburns, sometimes regurgitation, dysphagia, sometimes irritant coughing, particularly during sleep or during lying down, recurrent inflammation and irritation of the back of their throats. Sometimes patients might have, with long-standing reflux, abnormal changes occurring within the epithelium of the lower esophagus, causing metaplasia. So as you can see here, there's the lower esophageal sphincter, which sometimes allowing the reflux, particularly also sometimes precipitated with certain foods, and allowing the acid to irritate the lower part of the esophagus. And because the esophageal epithelium is not accustomed to that type of irritation by chemical irritation by the HCl, it undergoes abnormal growth of intestinal type of epithelium, which is supposed to be more resistant for the acid reflux, columnar epithelium, above the gastroesophageal junction into the esophagus. And this could stop at this stage, and however, because the metaplasia started and the abnormal cells start to grow, it might develop abnormal staging with this stage known as dysplasia, and finally carcinoma in situ, and then cancer. So how to diagnose? With radiology and then endoscopy and biopsy, which is the gold standard gold standard treatment and diagnosis. Biopsy during endoscopy, you will be able to see the red lines, and will be able to assess the transformation of the type of the epithelium from the esophageal to the gastroesophageal junction, and if there's a migration or creeping of the intestinal columnar epithelium into the esophageal surface, you'll be able to take some biopsies and send them for histology, and then get confirmation of or absence or presence of Barrett's esophagus. It's important to diagnose because Barrett's esophagus will require different managements. So the treatment is usually diet control, medical management with proton pump inhibitors, for example, and also diet control as well as weight reduction, and then endoscopic surveillance to make sure there is no progression to Barrett's esophagus. So surgery will be for patients who are having complications of reflux, like parasitic esophagus, aspiration, or peptic stricture, as well as failure of maximum medical treatment for at least 6 months. Then we will have to do surgery to prevent the presence or development of the complications later. So the aims of surgery is if there is dysplasia, which is the stage preceding the cancer, esophageal resection is warranted, and also if there is a paraesophageal hernia causing the reflux symptoms, it should be repaired. So reduction of the hernia and closure of the sac and creation of intra-abdominal segment of the esophagus. Also the strengthening of the anti-reflux mechanism by fundoplication and narrowing of the esophageal hiatus. So with fundoplication, there are different techniques. There is the most common Nissen fundoplication, depending on the degree of rotation of the stomach over the esophagus. So if it is 360 degrees, it is called Nissen fundoplication, initially by laparotomy, but now you can do it with laparoscopic techniques. And Pelsimar, for example, is 270. You will have also Tobey, which is 180 degrees, or Dor, which is 180 degrees, but anteriorly. Also there's esophageal lengthening procedures, or Cole's gastroplasty. Cole's gastroplasty is for esophageal when there's a peptic stricture and shortening of the esophagus, trying to create a new esophagus using the greater curvature of the stomach. It could be either partial and total fundoplication later on, so it's just a technique to cause more of allowing more length of the esophagus before doing the fundoplication. And that's the picture as you can see here. So it will do some incisions on the stomach and try to elongate the esophagus, and then doing later the fundoplication, either Pelsimark or Nissen or any other type. So the specific complications of the anti-reflux surgery: if you did an overcorrection, patient might present with dysphagia. Patients sometimes describe gas bloating syndrome. If there's a vehicle injury or aerophagia and inability to reach, then they will have a gas bloat syndrome. There may be technical failure like slip, Nissen, or breakage of the fundoplications due to loose strictures, stitches, or a perforation. Hiatus hernia is a protrusion of the portion of the stomach across the opening of the diaphragm that the esophagus normally passes through. And depending on the degree severity and the amount of the abdominal content protruding into the chest cavity, it's the subtypes. Type 1 is a sliding, where the gastroesophageal junction is migrating up in the chest. And there's a type 2 where there's the paraesophageal or rolling hernia, and this time the gastroesophageal junction is below the diaphragm. However, the part of the stomach is protruding through the esophageal hiatus to be close or to be on the side of the esophagus, so that's called the paraesophageal type. And there's also be a combination of both, when the gastroesophageal junction is above the diaphragm, as well as protrusion of the part of the stomach above the diaphragm close to the esophagus, or could be a complex or other types or other parts of the abdominal contents arising from the hiatus. And as you can see here, so there's in the normal esophagus, the gastroesophageal junction should be below the diaphragm, and if it is protruding above, this is the sliding part of the hiatal hernia. If there's below the diaphragm, but there is a part of the stomach lying by the side of the esophagus, called the sliding paraesophageal hiatal hernia, or rolling. So the clinical picture: the patient might be asymptomatic, or they might have symptoms of reflux, because one of the protective mechanism against or anti-reflux mechanism is the presence of the gastroesophageal junction not below the diaphragm. And then when the hiatus is high and the gastroesophageal junction is moving upward in the chest, this mechanism is lost, so that might also contribute to the symptoms of reflux. There's also mechanical complications if the parts or any abdominal contents are rising from the narrow hiatus to the chest and get incarcerated or get volvulus or rotated. It might result in intestinal obstructions. The complication, as I mentioned, is reflux or mechanical obstruction like incarceration, volvulus. So the investigation: first, we do a chest X-ray. You can see some of the abdominal content if they are large amount in the chest wall. large abdominal contents like in the stomach or colon, particularly so in type 4. So this is, you can see the stomach inside in the chest wall, in the chest cavity, and that's the lateral chest X-ray also showing the same. The Parim study, or the upper GI of the upper GI, here you can see, so if this is the hiatus and that is the esophagus, that is gastroesophageal junction. So as you can see, this is the sliding type of hernia. And endoscopy, then you can also see and assess the esophagus. So the treatment for type 1, medical treatment of reflux, the same treatment as reflux disease, could be surgery if there's a failure of maximum medical treatment, or if there's a mechanical complication. Type 2 and 3 and 4, it should go to surgery because they carry higher risk of incarceration and volvulus. So the surgery, during the surgery, we will reduce the hernia and excise the sac, close the hiatus, and suspend or fix the stomach. There are different techniques, so it helps when it is fix it to the lesser curvature or fixing it to the diaphragm. And then perform an anti-reflux like fundoplication. Then we will talk about the esophageal diverticulum. So a diverticulum is a sac arising from a tubular organ, from any tubular organ. In this case, it's esophagus. So if we classify them according to the presentation or the age of presentation or the pathology, etiology, it could be either congenital or acquired. Usually the acquired type is bulging diverticulum or traction diverticulum. If there is an increase in esophageal pressure, it might lead to bulging diverticulum or traction from fibrosis or traction by any other fibrosis, any other nearby organ. It could be also true diverticulum, where there is 3 layers, or false diverticulum, or also called pseudo diverticulum. One of the commonest one is Zinker's diverticulum, which is in the top of the esophagus, on the upper part of the esophagus, or mid-esophageal, and there is an epiphrenic in the lower part of the esophagus. So Zinker diverticulums is that's just X-ray showing Zinker diverticulum. There is a mid-esophageal one here, and also epiphrenic. So the pharyngoesophageal diverticulum, or Zinker's diverticulum, which is the most common type of diverticulum, it is a pseudo diverticulum, and it appears in the areas of anatomical weakness of the Killian's dehiscence, which is in the area of the upper of the dysfunction of the area of a cricopharyngeus muscle, and that's it, because the dysfunction of this muscle will lead to the development of the Zinker's diverticulum. So the clinical picture, usually the patient will have a sort of dysphagia because of the compression. When this sac is enlarged or is filled with food, then it will cause compressive symptoms. And then also because the food is stored or remains on that sac rather than going to the stomach, to the stomach or the root of the esophagus, the patient might report that he's having regurgitation of food which is consumed time ago. He'll have also halitosis or bad odor of the mouth, and also chronic aspiration. When patients get into different position, he might aspirate, and the food stored in that sac. So how to diagnose with barium swelling? We can see that there is a mass, there is a sac in the neck, in the upper part, filled with barium. That is an endoscopic picture, and this is the entry of the diverticulum. So with the treatments, usually if it is small and asymptomatic, there's no treatment needed. If the medium ones, then we can do a suspension. So if you suspect the lower part of the diverticulum, this will not put it in a dependent position when the food can accumulate. So if you suspend the base of it, or the apex of the diverticulum, which is more dependent, then the sac will not be able to have, or food will not be able to accumulate because there's not dependent anymore. So that is the diverticobexy. If it is a large, it should be excised and then closed, and the myotomy is essential in this case because this is where the dehiscence is. There's a Dolman procedure in which we can do endoscopic stabling of the diverticulum instead of having neck incisions. Then let's move to another important entity with esophageal cancer. So esophageal cancer is mainly arising in elderly men over 60. and it has been linked to as for tobacco smoking and heavy alcoholism as one of the risk factors. There is important precancerous lesion that we've mentioned that might cause the development of esophageal cancer. Plummer-Vinson syndrome, achalasia, reflux, paralysis usually when reflux causing paralysis esophagus, which is very risky. Sometimes also the corrosive injuries might also contribute. Plummer-Vinson is with an iron deficiency, anemia, and esophageal whips. So the symptoms, usually patients will present with dysphagia and odynophagia from tumor, and also pain due to the local tumor infiltration to the surrounding structure, because the adventitial layer of the esophagus is not very well developed, and so there's a local extension of the tumor in the patient with esophageal cancer. Patient also might present with respiratory symptoms from regurgitation, and they might develop also hematemesis due to the local infiltration or bleeding inside the tumor. And there could be manifestations of distant metastasis and advanced disease like liver jaundice in patients with liver metastases or pleural effusion. Also, there will be an enlarged cervical and supraclavicular lymph nodes, and patient will have also weight loss and cachexia later on. So laboratory investigation will show anemia, and if there's a chest X-ray, will show either pulmonary metastases or pneumonia from recurrent respiration. And if there's a large tumor, it can appear as a soft tissue mass with air fluid level in the posterior mediastinum. With a prime swallow, which is an initial assessment, you can see shouldering of the lesion, so there's a stricture here. With esophageal with endoscopy, this will allow us to have the site and extent of the tumor and take multiple biopsy to confirm the diagnosis. And in patients who are for palliative treatment, this allows us for dilatation or stenting. CT scan is a gold standard treatment to assess the staging and metastatic extension, local and distant metastases. Endoscopic ultrasound is helpful to ascertain the depth of the tumor penetration and lymph node assessment. The bronchoscopy is needed if there is a malignant fistula. So the staging is depending on the extent of the involvement of the different layers of the esophagus. So if it is limited to submucosa, it's T1, T2 with the muscularis propria, T3 if there's an adventitia, and T4 has affected nearby tissues. And that are different stages of the esophageal cancer, as you can see. So most common histological type is squamous cell cancer, which is compromising around 80% of the primary esophageal cancers. Usually they either fungating, ulcerating, or polypoidal or infiltrating. Adenocarcinoma can result in patients with Barrett's esophagus, usually in the lower part of the stomach. So how can we differentiate between an esophageal cancer extending locally to the stomach or gastric cancer extending to the esophagus? So the criteria in favor for esophageal origin is if there is Barrett's esophagus, if there is most of the tumor masses in the body of the esophagus itself, and if there's a direct invasion to the periesophageal tissues, and if there's a minimal gastric involvement and symptoms of esophageal obstruction. So the treatment is surgery for early stage tumors and operable patients with near total esophagectomy, either the right or left thoracotomy depending on the site of the tumor, sometimes thoracoabdominal if it is close to the gastroesophageal junction, or sometimes the VATS and laparoscopy, or transhiatal. A reconstruction can be done with a gastric pull-up or small or large intestine. As you can see here, most of the mass is in the esophagus with extension to the stomach. So we can also do preoperative radio and chemotherapy to improve the surgical to debulk the tumor and help in the surgical resection and emulate the micrometastases and improve resectability. So palliative resection can be done in patients with intractable hematemesis, or if there's involvement to surrounding structures. Usually patients, resectable patients or palliative treatment will be treated with stents. or laser therapy or brachytherapy in order to help the patients to have a normal swallowing. And that's in the lecture. If you have any questions, please feel free to ask. Thank you.